Got 7:02. Let's come to order as the Board of Health. And do we have anyone who wants to make public comment to the board this morning? Hearing none. A motion to approve last month's minutes.
So move.
Second,
Second.
all in favor?
Aye.
Approved. John, what happened?
What happened and what is happening? Yeah. Good morning, board. So first and foremost, I recently shared an update with the executive committee and put in your board report this morning, an update on health insurance costs here at RiverStoneHealth and through Yellowstone County. I won't go into too much detail with respect to Commissioner Morse, who couldn't be here this morning. They moved the Thursday morning, this commissioner's discussion meeting up to 7:30 this morning. So just for this week and this month, but we're going to have some more conversations with the county and talk about possible solutions and how we move forward here. While over 70% of our staff are going to be just fine because they're on employee only coverage, about 28%, almost 30% of our staff are going to see a material increase in their benefits costs. Now, some of that is within the 3 to 5% that you would typically see year to year, but there are several cases where folks are going to see as high as $450 a pay, $900 or more a month of an increase because of some benefits tiers that have been changed and removed. And then the high deductible plan is now the same cost as the traditional plan through negotiations with Blue Cross and Blue Shield. So we weren't at the table when those conversations were happening, but we have kept benefits through the county and we're part of that pool. And so we have to work through what that means for our staff and how that looks for our employees.
How much does RiverStone contribute?
$1,000 a month for a full FTE.
$1,000 a month?
Yeah.
Okay. So that, what I saw before, that generally covers the increase, right?
That is an increase for employee only plans. So for employee only plans, if you're an employee, we pay your health insurance benefits. But if you have a spouse or if you have children, you pay in to that. So there's these changes, these increases are the employee costs, not the RiverStone costs.
Okay. Okay.
So this is direct, significant increases in cost of staff. Yeah.
Do we offer health insurance to the part-time?
Yes, it's optional. They can elect in.
And do we subsidize that? We pay part of it.
Yeah, not to that same level.
In this case, a part-time, high deductible health plan staff member who is a single parent is going to see the highest increase. And that's exactly who we don't want to see the largest increase. So we also have a really interesting plan limitation that impacts spouses who both work at RiverStone. And so if you have two spouses that work at RiverStone and they have a child or they have two children, we have really interesting cases where, one spouse has employee only coverage with one child and the other spouse takes coverage with the other child. They are going to be more gravely impacted due to this change. And so we're working through how we support our staff, how do we get to the bottom of why these changes happened, and then what can we do about it? How can we support the team? Our understanding from working with the county is that they're prohibiting employees from being able to make a change. So this change goes into effect August 1st. And they will be stuck with a higher cost plan and unable to make any changes to their health plan until December for the calendar year 2027, the start of new plans. So there's about a 4 to 6 month period where folks will be stuck with higher costs and not able to make any changes. We've requested plan data so that we can make some more informed decisions about employee health benefits and understand the fiscal impact to RiverStoneHealth and the city county health department. But we've definitely not received what I would call a cooperative response from county HR at this point. So I have a more formal request to make later today. I'll make that direct to the county commissioners. And we're going to keep advocating for our staff to get additional information and make sure that we can get to the bottom of this. We pay into the plan. We are a supportive partner with our county, and we always have been. And so we just want that same level of support and cooperation back so that we can understand what the true impact is to our staff. So that's the biggest hot button item for the day. And we are seeing this, we're seeing these changes very much due to federal policy change, HR1, OBUBA, the One Big Beautiful Bill Act, and how it's impacted the insurance market is driving, for-profit corporations like Blue Cross Blue Shield and HCSC to make really poor decisions when they're the only game in town to up the cost and to basically bring the cost of high deductible plans to the same level as traditional plans. So all of those market things are shifting and they're going to impact folks. We are not immune. We are not the only ones that are going to see this year. So more to come. Had a great hospice golf tournament. Thank you, Coach, for coming out. Thanks all for being there. The foundation is in flux, but our communications and marketing team and our hospice team really stepped up and made sure that we had a successful event. So we're going to keep it going. And it continues to strengthen our hospice endowment, which is a really good thing. And what I told the foundation folks earlier this week or last week is that they ought to be proud of the money that they have raised for hospice, because our hospice endowment is now fully sustaining hospice programming for anyone here in RiverStone service area. So that is a testament to the hard work that the foundation continues to do. The second hot button topic, you might have heard something about this proposed forensic behavioral health facility in Laurel. We continue to work with the county. We continue to work with our local folks in this behavioral health working group. And no good deed goes unpunished. What started out as a gap analysis that on the very first page pointed out that we were in support of such a facility being built. We just wanted to understand how the rest of the behavioral health continuum was going to be impacted. Was politely or impolitely called out in the environmental assessment that the state published. And they went as far as to say, well, that that gap analysis that Yellowstone County behavioral health providers and entities created together and worked so hard to build a community around is inaccurate and generally irrelevant. However, I've pointed out to you all before, I've shared the document with you in the board packet this week. Our group is focused on workforce and educational pipelines, pre-release planning and care coordination, data transparency and improved systems, step down capacity and improved housing need, wraparound services for folks that are in the system, as well as Medicaid and payment and authorizations issues, none of which are issues that are irrelevant or inaccurate. The inaccuracy in the report was the assumptions we made on staffing, and that was it. We made assumptions because we didn't get any information from the state on what they were planning or what they were trying to do. And so when we made those assumptions, we used numbers from the current inpatient psych facility here at Billings Clinic. And to call our assumptions inaccurate is one thing, but to label the entire document as a bunch of BS, because we want to be a good partner. We want to work with the state as always, but they're unwilling to work with us, and they're unwilling to meet the behavioral health community where we're asking them to meet us. So we'll continue to work with our legislators. We'll continue to work with the departments involved at the state level, and we'll try to make things better in the behavioral health continuum of care for everybody that we serve. On Monday, June 8th, you all got an update on the Billings Superfund site. We don't have anything to do with that plan or remediation as the local health department. It's all being done by the EPA and DEQ at the state level. So you can continue to read about perchloroethylene or PCE and the why it's in our groundwater here in downtown Billings due to years and years of improper and illegal dumping by dry cleaners and industry. But they have a cleanup plan going for that. The initial kratom lawsuits continue to be processed. Inspections continue across the county. The county attorney expects it to be another 3 to 5 weeks until a judge is selected and the cases are consolidated. And so we'll continue to provide updates on where we are in the process there with the county attorney's office. But we've done our part and we've provided all the information to the county attorneys so that they can uphold the law. We're also getting ever closer to launching mobile dentistry on the WOW. We've had a couple recent donations, $25,000 gift from the Bear Family Foundation to help support mobile dentistry, along with gifts from Yellowstone Bank for Childhood Advocacy Center. We got another gift during that Federal Home Loan Bank process from Intrepid Bank for $8,700 to help with. And so we're up to just over $51,000, and we're applying for a second community gift for about $20,000 to $25,000, hopefully, from another local corporation that'll help get us over the hump and fully fund mobile dental access so that we're able to start providing mobile dental care. And that'll fund the equipment purchase, some of the staffing, and get us moving. Also, we hired a behavioral health specialist for SB2's Career Center. So we'll be able to provide on-site behavioral health support at the Career Center in the West End, which is great news, and continue to expand our school-based health access. A couple great things in partnerships. We have 2 new ASDO students, Arizona School of Dentistry, join our dental team to train this summer. We were able to help a couple libraries across the state get AEDs, Narcan, and stop the bleed kits in their libraries. And then we continue to work in workforce development with trying to work on apprenticeships with the state and Secretary Swanson, Department of Labor and Industry, as well as internal development of our own medical assistants. And then we also continue to have our ongoing quarterly leadership development program for our internal leaders and managers and emerging leaders here at RiverStone. So lots to do in leadership development, and also had the opportunity to present at the Frontier Health Conference a couple weeks ago with the American College of Healthcare Executives right here in Billings. We continue to go on into leadership. We're going to receive some pro bono support from Cushing Terrell to help us redesign and reimagine what the corner without the colonial could be and could look like. And so we're engaged with them on that project, as well as engaged with them on starting to think about and plan out what could a new Joliet clinic look like at our rural site, and working to progress something here for the corner and to replace it. What else? Moving on to protection, we submitted our reaccreditation packet to FAB. FAB is the Public Health Accreditation Board. And we were one of the first accredited health departments in the state, and will continue to maintain that accreditation for as long as possible. So we're anticipating an accreditation review visit here in the next couple months, possibly. And the Board of Health involvement is part of that visit. And so we'll be presenting to you on what that means for us and what that looks like. But this is a voluntary accreditation. We don't have to do this, but we do it because it puts us on par with the top health departments in the country. It evaluates and assesses our department's capacity to deliver high quality public health services to the community. And shows that we are focused on continuous improvement, accountability, and public trust. So we'll continue to make sure that we're accredited. You don't see a flu report or graph this month. The respiratory season is officially over as far as monitoring is concerned. However, there are some infections that linger out there. Primarily, we're still very concerned about measles. As of June 4th, over 2,000 confirmed cases were reported just in 2026. In 2025, we've almost equaled the entire total of 2025 so far. So far this year, we're at 22,030. Last year, total over 12 months, we had almost 2,300 cases. So it's something to be concerned about. Measles is obviously back and here to stay in the U.S. for as long as there is a lack of public trust in vaccine, which are highly safe and effective. You wouldn't know it. Also, with the World Cup being here, we've been watching across North America, listening into the Public Health Operations Center that some private entities and universities have created to just watch and see if there are any additional outbreaks of illnesses happening because of this highly attended event. And then one last thing here locally, our environmental health and public health folks are engaged still with the local hotel, the Howard Johnson here on the south side. They are still having Legionella remediation ongoing. They did one round of treatment. However, we did retesting and found additional Legionella spores. And so they need to do either additional 1 or 2 rounds of treatment. And so we'll be meeting with them later today. Most of the samples that came back post-flush were, just for comparison's sake, the minimum acceptable would be 5 colony forming units or CFUs. And there were several locations around the facility that were over 2,000. And the rest were very much over 100, 200, 400. So there's still an ongoing risk there. So we're working with them to continue to notify any potential guests. And this next round of remediation, we're going to politely require them to do the remediation that CDC and we as public health recommended to them in the first place, which is hyperchlorination. And they will need to close their hotel for a minimum of 24 hours to make sure that they flush that water system and hyperchlorinate the water supply. So we'll work with them. We're going to meet with them this afternoon, talk about the remediation plan, talk about next steps. But this is what they have to do to keep their guests safe.
Is the remediation just in the water system?
Yes.
But no other. Okay.
Yeah, they don't have any central heating or cooling, so it's not in a cooling system.
No,
It's just the water system.
Service.
Any questions?
Hey, John. John?
Yes. Yes,
This is
Steve.
the man in the space. I apologize for being late. Forgot the hour time change. and obviously I'm in the hotel business, so at what point does RiverStone, I guess with Legionnaire, and I'll just refer to as Legionnaires, at what point does the health department step in and I hate to say it, but close? And I'm not advocating closing properties for the benefit of me. I'm not, but I look at it and go, okay, so I happen to know the operator, but there is it's a known public health. And I guess the question is at what time do we potentially become liable if somebody gets sick and somebody says, well, Riverstone Health, you knew about this. Yes, you've taken some steps to tell them to do this, but I got sick. And so, potentially we're involved in a lawsuit. Where does Riverstone's responsibility to say, this is a true health concern and shut it down? This would be like salmonella in a restaurant. At what point or where do we have to take that step?
So, couple things. It's very much different than salmonella in a restaurant because the risk profile is different. If I walked into that hotel and took a shower as a 40-something in pretty good health with no lung conditions, I probably wouldn't contract Legionella or Legionnaire's disease. I probably wouldn't be impacted. What we do in this case, where if I went to a restaurant who was serving me food this morning, bacon and eggs with salmonella, it wouldn't really matter. I would probably get sick. And so the risk is a little bit different with Legionella. And so what we've done to manage our risk is to mandate that they share this information with every single guest that check in, that they let folks know that they have a potential problem. And if there's anybody staying in that facility that is immunocompromised or that has COPD or that has a long history of smoking and may have lung issues, et cetera, is elderly, there's a stratified risk profile. And we share that with them. And then their responsibility is to their guests. And so our responsibility is to protect the public and to inform them that there's a problem in this facility. And so that's one of the reasons we went public with the media to share. We want people to know if you've stayed there in the past several months, or if you plan to stay there, here's your risk. And if you've experienced any illness, side effects, symptoms, please let us know so that we can investigate that illness, that we can determine whether you became sick at the property and take appropriate action now. At this point, we are at that point of, if they are not going to comply with our recommendation and the CDC's recommendation for immediate remediation with hyperchlorination, say that 10 times fast, then we will exercise our authority to remove their licensure and forward them to the county attorney's office for closure and enforcement. It's the long story of, are we an enforcement entity or are we a regulatory entity? And where does my authority lie in the state of Montana as a public health official? And what actions can I do versus what do I need help from supportive entities and agencies to truly do? So a long answer to say that it's a different risk profile. We're working with the business. They tried to do a remediation that would kept them open. It was an approved remediation from ASHRA, and it's worked in water supplies and systems across the country. We provided them with some warning that because we felt their water system was so out of compliance that it may not work. And now we're at the point of saying to them, listen, you need to do a second remediation with a more effective solution, and you need to do it ASAP. And so if they're going to refuse to do that, if they're going to refuse to close, then we're going to step up that enforcement capability. We're also going to work with, there are a couple long-term folks that are there in living conditions. And so we're working with those folks too, to make sure that they'll have potable water and potentially another place to go when this place is going to have to close for 24 to 48 hours and flush that whole water system.
I guess the follow-up question to it would be is, yeah, I guess, and it's on, so it's the hotel owner's responsibility to notify guests.
Yes.
I can't believe that if if they're notifying guests, and this is just a comment, if they're notifying guests, why in the hell would anybody stay there? I guess would be my first question. But be that as it may. Okay. I was just curious, and all I think of is Philadelphia, what, 20, 30, 40 years or whenever it was when it broke out. And I guess that was in the air cooling system that they had their problem at.
Correct.
So,
Correct.
okay.
That's the other piece of, risk stratification. When we look at this, you can go in to that hotel right now and drink the water and be fine, even if you did have a lung condition. You wouldn't contract Legionella by drinking the water. It has to be breathed in. It has to be water vapor. So you have to take a shower or use the hot tub or be in that aerosolized airborne environment. And so that's the other piece to this is, what happened in Philadelphia, why we have the name Legionnaire's disease was because it was American Legion convention. And think of your demographics for the American Legion.
Right.
Very older population, and they were more susceptible to that. And the fact that it was airborne in the HVAC supply, it really led to the number of deaths and the number of individuals that got sick and gave us the name Legionnaire's disease. And so it's different in this particular setting because it's in the water system. There is, we were on a call earlier this week with another entity in another state. And God forbid this will not be us. I will not make it us. But there's another public health agency in another state on the East Coast that has been working with a hotel on Legionella for over 6 years.
Oh, Jesus.
Yeah. So this is happening in multiple different places across the country. Aging infrastructure is an issue. Lots of different things to look at, but it's being taken seriously, and we're going to get a resolution soon, or we're going to take a different approach.
Can I ask one more question?
You may.
Because, and this is a personal question now, so because of, you just said age. So that property is probably the age of my property or very close to my age of my property. So what do people do, or how do people check this or validate, or what has created that reason? And I don't know if I'm asking the right question. I guess my question is, I got a 60-plus-year-old property that, I think we operate well. But I've never flushed my pipes. I don't know what's caused or or how this got created or how it gets created.
So a lot of different things. Water pressure issues are one thing. So do you have adequate supply and pressure? Stagnation. Are there rooms that aren't very often used? So the more you get guests through your rooms, the better off you are. One of the most important factors is having a fully functioning water heater that will heat water over 140 degrees. If you don't have a fully functioning water heater that is heating your water appropriately, then this bacteria is going to grow and take over your water supply. So
Okay.
the hot water is one of the best things to do. Utilizing the water is the second best thing. And then creating, and that's actually, this is something I would love to talk shop with you offline about, is
Yeah.
how does the hotel industry focus on water management plans? Because we're working with this individual hotelier who owns a couple different properties, and they've never heard of a water management plan or know, how to take care of their water system, make sure their water heaters are at the appropriate temperature, et cetera. So we're doing a lot of education in this particular instance. And it might be something that we take to the chamber or to a local hotels and inns group and share, hey, here's great ways to prevent this from happening in your property.
Okay, I would love to, because I quite honestly I would be with the operator. I would agree. Yeah, I haven't heard of that. So thank you very much. I apologize for asking a personal question, but
Thanks, Steve.
I think it was good questions. Not just personal, I think they were important. I'm guessing, but the local hospitals continue to check their water supplies.
They do. They do.
It's not that hard.
We're going to work with them too. No, it's not. This is something I've dealt with being in operations in a hospital and in a VA hospital. This is something that we looked at nationally, and 15 years ago, we had one case in one VA hospital, and we went around the country and put in hyperchlorination, UV treatment, and other water system treatments in back systems and water supplies for every VA medical center because it was becoming an infrastructure issue. Facilities were aging, water systems were getting old, and this was going to start happening. The frank fact is that it's living in your water now. It's just that your hot water is taking care of it. The water treatment plant is taking care of it. Your water systems are being used appropriately. It's just a matter of when it gets out of control and really blossoms.
Other questions or comments for John?
Are we actively seeking a director for the foundation and income is held up?
Right, our income is holding up pretty darn well. Yeah. Part of that is our grant writer, Carissa, who's just doing a stellar job of bringing additional foundation and philanthropic dollars in. We've had a little decrease in private donors because we haven't had anybody really building those relationships, making those calls and staying on that. But we will be launching a search soon for a new director role position, and then trying to figure out what do we do with foundation staffing and what does that look like? And that could be where we'll roll up our grants program and our volunteer program potentially into that foundation entity and continue to move forward because we're going to need them for capital projects for pretty soon coming up in Joliet and here on the corner.
Thanks, John.
One quick,
Michael, go ahead.
I forget. To what extent does the roving dental clinic, what kinds of procedures are they capable of doing?
So they're going to be, what my understanding is, and Eric can correct me, is that there'll be a full scope dental clinic to be able to do pretty much all of the things that we do here on site. So we don't do like many crowns or dental surgeries or things like that. Extractions, but they can, my understanding is that they're gonna have all the equipment necessary to be able to do, if they identify the need for a filling or for some minor dental work, they'll be able to do it in the well.
Yeah, I'd say basic restorative services. They'll be able to do on the clinic, as well as they have a mobile x-ray. They have all the stuff to do preventative dental care and basic fillings.
They won't be doing complicated extractions or things like that. That would be better done in our main facility.
They can refer those children primarily, but refer those children to, or, okay.
Yeah, and honestly, at this point, like a lot of the more complicated pediatric cases, we're referring out to pediatric dentistry where they do more sedation and, you know, some of those kids need more sedation if they can't get through it with just, basic Novocaine.
Thank you.
Thanks, John. Megan, we'll let you keep talking.
I don't have a whole lot to add. There was not a lot that happened in the last, 3 weeks from the last time I wrote my report that John hasn't highlighted. The biggest news is really around our residency transition. So we have our new group of interns who have formally started orientation. Yesterday was their white coat ceremony, and John did a great job of introducing RiverStoneHealth and our services here to the new group of residents. And I've been meaning to send you an email. I really appreciated your words yesterday. I think that was really inspiring for them. So we welcomed them yesterday. Our third years, the graduation is on Friday. So we will be saying goodbye to our group of third years. Several of them are staying on a little bit longer to hit their numbers. We have continued to have some challenges with some of them had leaves during their residency for paternity leave that has extended their residency, but are staying to try and hit their clinic numbers. So we have a number who are staying on for a couple of weeks to a month or so. But yeah, it's always an exciting time of year in our residency and faculty as we see this changing of the guard take place. We had our faculty retreat at the end of May. We are in the process of our ACGME cycle. So we have our big ACGME review coming in September that looks at the residency and making sure that we're meeting all of the criteria, all the national criteria for being an accredited residency. We had we do annual resident surveys, and our resident survey this year came back with some concerning trends that that we're working on addressing. And so partly because of that, and partly just because we were having an ACGMA survey coming up, we had our mock survey done, which went really well, really didn't uncover anything that we were not expecting. More just some resident discontent really is what I would say. And I think some of it is a mismatch of what are probably normal, which are misunderstanding of just what expectations of a residency is, and how, some of the things that they complained about are things that we can't change because they're ACGME requirements, and just a mismatch of understanding of what we can impact and change and what we can't, because you're a resident, and there are guidelines and competencies and rules that we have to follow, and you have to meet those things in order to graduate as a physician. So we're working through that process, and I think our faculty retreat was a great way for us to really identify and figure out our path forward. APP residencies launching. We had 5 candidates who interviewed for our APP residency last week. And we are in the process of narrowing that down to 2 candidates who will be starting with us in October. So we're pretty excited about that. And everything else is in the packet. I think we've talked the biggest public health issue, besides still just the situational awareness around measles, is the continued shortage of bicillin for syphilis, which has been a bit of a challenge, but we're managing, we're ordering. We have a way to order emergency doses when needed, and I've been working closely with our communicable nurses to get those doses ordered and here when we need to get them, but that continues to be a bit of a challenge and will be into 2027, and now appears. So other than that, if anyone has any questions.
Any comments or questions for Megan?
Hey, Megan?
Yeah.
Is syphilis on the rise, staying about normal, decrease? Based on this, I would say it's probably increasing.
Yes, so it has been increasing. It's been on the rise nationally and locally for the last couple of years. We have we've seen an increase, which is why there's more awareness about it and more expanded testing for it. But yes, both nationally and locally.
What's the frequency of ACGME reviews these days?
So I believe it's typically a 3-year cycle, but you can, if there are concerns that get brought up or brought forward, they can initiate a suit.
Annual reviews.
Yeah.
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 Yep. Thank you. Other questions for Megan? Should have been a doctor instead of a bean counter. Only get reviewed every 3 years. Speaking of bean counting,
You don't get sick of the doctor.
That's true.
speaking of bean counting, we have a full, thank you, Megan. We have a full bean counting list of reports this morning. So Spencer and Shanna, enlighten us.
I'm gonna let Shanna take over. We a very detailed budget presentation occurred on last week, which I was not present for, so I'm gonna let Shanna.
Sounds wonderful. Well, good morning, everyone. I'll start and run through some highlights of our April financials and then spend the bulk of the time on the fiscal year 27 budget. This is a hard part of the year where the financials seem to become less and less relevant as we move into the next fiscal year. But just to comment on a few things with April, cash totaled about 15.4 million at the end of April. For context, this is an increase of $2.4 million from April of 2025. So if we're looking at our days cash on hand in April, we end at about 78 days. And if you remember, our goal really for this fiscal year is 84 days. I think we're going to get pretty close to that goal. Obviously, this is crunch time in the fiscal year wrapping up as we near that June 30th date. The one thing that we are navigating right now is an increase in receivables from hospitals as it relates to our residency. And so we've got about $1 million owed to us from Intermountain, which would be wonderful to get as we near this June 30th date to help that days cash on hand metric. That being said, I still think we'll get very close without that. I would suspect probably about 82 days if we don't receive that payment. So really close to that 84-day goal. Back to just some of the cash conversation, we're at about $12.5 million unrestricted too. So I'd say the cash position for the organization has definitely stabilized more. And so as we enter next fiscal year, obviously we'll continue to manage and monitor that, but concentrate a little bit more on some other financial metrics during the next fiscal year versus just that days cash on hand ratio that we've really put a lot of concentration on. In April, patient services revenue, we were under budget about 303,000, but if we're looking at that, or excuse me, that was our year to date, about $303,000 year to date. And so the bulk of this variance for our patient services revenue through April is in our Medicaid. Really the big thing that's impacted us throughout the fiscal year as far as variances is our wages and benefits expense. We're about $215,000 under in the month of April. And when we're looking at year to date, we're about $2.1 million under, really due to vacancy savings across the organization. For context, we are in April, we are at 323 FTEs and we had budgeted in 353 FTEs. We continue to see a little bit of increase in that. When I pulled this together for finance committee last year at 327 FTEs. So relatively, I guess, close to that budgeted number, are working towards that. Our fiscal year 27 budget includes about 340 or so. We have 360 million, but we really tried to essentially incorporate an allowance in for what we're seeing for vacancies. So we budgeted in 369, but didn't assume that we'll be more at 340 through the fiscal year, just to try to get that wages and benefits number a little bit more realistic in the fiscal year 27 budget. For the month of April, the financials represent net revenue of about 101,000 compared to a budget of about negative 85,000. And we're looking through 10 months of the fiscal year, we're at about 2.8 million compared to a budget of about 107,000. Again, the largest variance in that is the wages and benefits. So of that $2.8 million bottom line, $2.1 million of that is the variance in wages and benefits. Any questions on the April financials before we dig into the budget?
When we throw a variance like that on salaries and wages, is it because of vacancies that when we budget,
Yep.
we budget someone for the whole year and they may not be hired for 6 months?
Really, in the fiscal year 26 budgeted, we budgeted all the vacancies, all the open positions, everything across the organization for the whole year. And we tried to account for what we assumed they would use for vacation and sick leave. And so we did that on our attendance policy. So we budgeted all the FTEs at about 96% attendance. Fiscal year 27, we tried to take a more realistic approach at that. So we looked at all of our open positions, made a best guess on when we anticipate filling those. And so only put the FTE in across those months, and then incorporated a vacancy savings across the entire organization of about 10%, just because that's kind of what we're seeing right now. Really just to try to make that number more realistic as we get into the fiscal year 27 budget.
Thanks.
Yeah. Any other questions on that April financials? Let's talk budget. So we've spent obviously quite a bit of time the last few months running through the fiscal year 27 operating budget for RiverStoneHealth. Overall, I would say for the organization, we've really incorporated modest growth in, which is really what we've done from the previous fiscal years. Just really keeping overall service demand and activity volumes relatively stable. Within the packet this month, I included essentially a key financial metrics document. So if you're following along in the packet, really giving you an idea of what we budgeted in for patients, for activity, and for the associated revenue with those across the different areas of the organization. And so essentially that key financial metrics is broke down by the departments across the organization. So you can see more or less the assumptions that we used in those revenue generating programs across the organization. We've included what we have in the fiscal year 27 budget, and then the line below that is the trailing year. So April on back 12 months, just to give context of what we actually are seeing compared to what we budget, really showing that we've kept everything, like I said, modest growth and relatively stable across the next fiscal year 27 budget. We have a few more cautious revenue items that we've budgeted in. This is obviously due to the Medicaid changes that we spent quite a bit of time talking about, as well as the 340B Medicare drug price negotiation programs. When we're looking at the impact of these, best guess in the fiscal year 27, we're anticipating about a decrease of $871,000 in Medicaid. That's essentially a 5% decrease for us. And really the assumption with that is that those patients shift to more of a self-pay type group. And then we also incorporated an increase in bad debt associated with that, as obviously we'll see an increase in that as those patients do move over to a self-pay status. Our budget also includes about $376,000 decrease on the 340B program. That I feel a little bit more confident in than the Medicaid number because we know the drugs that are selected, we know the volume of it, and so we have an idea of what the impact of that will be to us across the organization as far as revenue goes. The other big thing that we incorporated into the fiscal year 27 budget is about $1.3 million investment in staffing as we continue to be our commitment to be the employer of choice. And so that was something that we penciled in right away into the budget and really spent a lot of time working around how do we do that and how do we do that into the next few fiscal years. And so our budget approach this year really did include like a 5-year budget trend. And so we're really looking at how we continue to increase those salaries while we're navigating some of these other uncertainties or some of these other decreases in revenue that we anticipate seeing. So as I've talked about a little bit before, we took a really good look at compensation this year, which was a really cool thing to see pulled together organizationally. So essentially a group across the organization spent, 4 or 5 months going through every single employee within the organization, looking at years of experience, really taking a look at our wage tables and trying to get people moved more in line with their years of experience as it relates to the proper classification for them across the organization. Obviously, this isn't something we're going to be able to do all at once. It really is like a 5-year project for us organizationally, but taking a big chunk of it into this fiscal year with about a $1.3 million investment in that. Some of the offsetting items in our fiscal year 27 budget, as I talk about the decreases in revenue and the increases in expenses, we will see a decrease in depreciation just as things kind of age across the organization. And we can continue to work on our overhead cost allocation. So we've got that about $17,200 per FTE. It was about $19,000 last fiscal year. Some of that has to do with just redistributing some of our admin costs, but we've also looked at a couple of our other larger contract services across the organization. Brought some of that in-house as well as pared some of that down or looked for a little bit lower costs as we look to continue to really manage and monitor that overhead cost allocation across the organization. All of that being said, we've got the fiscal year 27 proposed budget at about a positive $66,000. Again, we always try to make that as close to break even as possible. A lot of work into this one as we look to do that and navigate these things that we see coming the next fiscal year. We have. Questions on that piece?
Any budget has weaknesses or exposures. Where do you think the big exposures are in this budget?
So a couple of
Risks.
things. Yep. So 340B, right after we analyzed all of this and got it drafted and sent out, we did get notice that we're going to see an increase in some of the expenses with our 340B drugs. That could be a tune of about $400,000 across the organization. Those are things that I just don't have a lot of certainty behind. But I do know that we've tried to budget in a little bit conservative pockets, as far as like the wages and benefits. So hopefully some of those things could offset that amount if we were to see another item like that hit the budget. But I would say the biggest uncertainty this next fiscal year is Medicaid. Just really not sure what we do across the organization for that. I did sit in on a CFO crawl across Montana this week, and they were saying that some of the organizations across Montana were budgeting in more like a 21% decrease in that. And like I said, we've got 5% in. I said, when we talked at finance last week, this might be the first year we'll ever have to come mid-year and look at a budget revision or sitting down and really taking a look at our budget. And to me, what would call for that is if we're seeing a revenue item that was way lower than anticipated, obviously, so we wouldn't get off kilter with our expenses through the fiscal year. And so we'll continue to manage and monitor. Our financial reporting is really up to date. And so any sort of variance that we see within that, we'll be able to react if we do need to look at rebudgeting.
Other questions? Spencer, any comments?
No,
Any questions?
just appreciate kind of the thoughtful approach to budgeting. It's challenging with all the moving targets and trying to balance the welfare of staff and the welfare of the organization is always a challenge. So appreciate that it's the approach to try and find a good balance there.
A couple more budget items.
Yeah.
We also have included in the packet the capital budget, the proposed capital budget. And so that is also something that we have if we look at kind of a cushion for us organizationally. So right now on the RiverStoneHealth side, we have about $502,000 in capital budget items into the next fiscal year. some of those absolutely have to happen. We've got a more enterprise-wide system with accounting included in there. We've got some other medical dental equipment. The bulk of the infrastructure type improvements, capital improvements come through the Yellowstone Health Partnership budget, so those aren't included in this RiverStone Health one. But as we look at some of these items, these are things that will obviously wait. We could pull the trigger on later in the fiscal year and, you know, save the cash if something were to happen or some of these projections might be off. And so, like I said, included in there, about $502,000 in capital for fiscal year 27 for RiverStone Health. And then the other thing that I've included is an updated mill levy allocation. We finalized the budget. I did bring this to you last month, but we've had just a few changes as far as moving those around in the different programs across public health. The bottom line, the dollar amount did not change, but just allocating across those different areas of the organization as we put all of the grant money in and all of the FTEs and just saw where the gaps did exist in those public health programs. So no changes in the total amount, just a little bit of a change in the allocation across those different programs for the organization.
Hey, I got a quick question on, actually the building itself, given the age of the building, water heaters, roofs, those kind of things. I just assume we have a review of those on a yearly basis, semi-yearly basis. I would assume the condition of those is still valid. Replacing a roof or some of the major air conditioning equipment that we have or air handling equipment would be very expensive. Is there sort of a thinking of planned obsolescence on some of that so it doesn't all come at the same time?
That's a great
Because those
question.
things are big ticket. Those are big ticket items that unfortunately occur. I mean, trust me, they occur. And when they do, it's sort of like a big gulp, and inevitably they seem to occur mostly at the same time. So just a question, thought.
That's a great question. And so, as I mentioned, this fiscal year, we really did look at a 5-year plan across the organization, and that related to capital as well. And that's honestly something that really hasn't been done organizationally. I think that we had some work to do on that. And so within this fiscal year budget, mainly on the Yellowstone Health partnership side, we've included some boiler replacement, some air handler replacement, and then we'll start some pod work in the clinic. And so we've essentially across the years taken a pot of it in the clinic, and we're going to work on all of the the upgrades that would be needed into those different areas of the organization, as well as within the Little Anderson Center. And so starting to work across the floors and make sure that we're doing the necessary upgrades across the infrastructure so that we can take care of some of that deferred maintenance. And so I would say that we have done a good job this fiscal year, really trying to identify those things that do need to be done. I mean, obviously, there's always uncertainty within the capital side. And so we will wait to pull the trigger on some of those that are more controllable until the end of the fiscal year, in case we do have any of those unplanned things pop up related to capital.
So, Steve, I'll just add to that as well. We're moving our facility infrastructure more into a plan similar to our technical infrastructure, in that we're looking at the useful life of those assets. And we're incorporating that useful life into our budgeting process. So we know that if a boiler, for example, lasts 20 years, we are going to be planning that expenditure is coming, so that there's always that risk something could go thump in the night, as you said. But I do think we are being far more intentional in the reality that you do have to replace that stuff on a regular basis. You can't run it till the wheels come off. And I think as you walk around campus, you'll find that there's some areas where, because we bought new, everything ages out at the same time, and we're really trying to move off of that. Hey, it's new, it looks great, to what does ongoing maintenance look like to make sure the assets last as long as they can.
Okay, that's good, because those are, you're right. Everything's opened up. It's new. Everything breaks at the same time. So congratulations for looking at it that way.
Else?
That's all.
Other comments, questions? Hearing none, can I get the mother of all motions to accept and approve 5 things that are under the finance committee? John,
I can make that motion.
second. All in favor?
Aye.
Opposed, same sign.
Aye.
Motion is accepted. Thank you, everybody. Public health policy.
We met and, usual, our opening, the, general updates from John, you've covered, most of those. I think else. Talking about the rural health project in our program.
Yeah, we'll be talking about that. I'll talk about when you're done, I'll bring up the legislative agenda so we can review that with full board.
Okay, yeah, that's the other thing that we, I think we. One page document you see is the, legislative priorities checklist, which has been reduced to one page. Smiling. And I think staff did a great job because I think, everything that was in the report really is in there. It's just kind of reworded and, I don't think there were significant additions or deletions. But will be distributed to candidates and legislators during the year. And then the second document, which is 2 pages, is sort of an internal memo, just give me more detail. And I think the committee has approved this. That it's up to the full board today to approve this document. I will actually move that we, well, I guess we don't have to approve that, do we? It's not. We don't have to approve. Any questions?
Questions for Brent, comments?
A question for Brent on the legislators, or does it make, probably doesn't make sense until they're elected to almost an open house or on health policy or the potentially legislative priorities. I guess it does make sense only after they're elected to have that, to sort of have that open house to provide education. And I don't know if there's any benefit to doing it beforehand so people understand a little bit more or more educated, or are they just trying to get elected?
Yeah, so it's a double-edged sword, as you pointed out. We are going to, one of the things that we've done regularly, and that John and Lil have done prior to my arrival, was share this legislative priorities document with potential legislators. And so now that the midterms have passed and we know who's going to be on each side of the ticket, Carrie is going to help me draft up. You're going to draft up an introductory greetings and congratulations on your, midterm victory sort of thing, and share it out with all the legislators who are on the ticket. And so we'll be able to share out our legislative priorities, share a brief introduction of who is RiverStoneHealth and why does that matter, and ask those questions of, you know what, you may not agree with everything that's on here, but pick 1 or 2 things that might interest you, and how can we work together? So we'll do a little introductory, and then we do a more congratulatory after the general election and say, hey, welcome to the party. We'd love to have you here on site, get to know us a little more, understand our priorities that we've outlined, and host them at that point.
I got a stupid idea. Does it make sense? And I know the board doesn't have representation in all of the districts or within the city, but does it make sense for those that are in say my district, which is basically downtown, that it's referenced, or feel free that and maybe it comes from me or not, I don't know, is that we as board members have our constituents within those legislative districts. And so to know that, oh, Steve Vorlick is on the board of health, please feel free to reach out to him. So somehow we personalize it so that
Yeah.
we're constituents, and that there may be an opportunity either after they're elected for us to vote or to have them come together, but we as the board are reaching out versus you as the staff member. I don't know if that makes sense or how that would work, but it might be an opportunity to garner more exposure for the organization that's not coming solely from staff.
Yeah, I'm happy to do that and share, hey, these are, even add a board list. And if I know who's in what, we know who's in what district, we can say, here are our Board of Health members in your local district.
Right. I don't know.
I'm the face they get tired of seeing in Helena. When I walk in the room, they all roll their eyes now, but
right.
You can join me.
Okay.
At any time.
I'll have time. I'll definitely have time.
Actually, I had a question. We also have the county report attached. Well, this is from Montana Hospital Association, I guess. I hadn't seen this before. The
list, yes. Yeah. So one of the things that I shared with everybody in the packet is the list of legislators. So there was a comment last meeting, how do I reach out to my local legislator and elected leaders? And so I shared, MHA publishes every year after the midterm elections, who's on the docket and who will be in the general election. And so within the packet is a MHA document that shares by district who your local legislators are, who our local contingent could be, so that you can reach out to them individually. And if you have relationships with anybody listed on that paper, when we do share out the checklist and other things, feel free to reach out and say, hey, if you have any questions about anything going on at RiverStone Health or any of the things that are listed here, I'm happy to chat with you anytime.
yeah, I see they have a partisan lean on some of them. I guess
That's really an analysis document that shares kind of by district, which way the districts are leaning and which candidate has the best chance of success.
Oh, the district.
Yes.
Oh,
Yes. So not really the individual candidate,
I thought.
but it's by district of, leans Democrat, strong Republican, all of those things.
Right. Okay.
Yeah.
Thank you.
Yeah. And the overall analysis, just while we're on the subject, I listened into both the Primary Care Association and the Hospital Association. While we had a couple key candidates who really support healthcare and public health causes get primaried out, the overwhelming majority of candidates that we supported, quote unquote, or MHA supported through their efforts, did really well and will continue to serve in the next legislative session, hopefully. So all of the changes between highly liberal or highly conservative and vice versa, it all kind of came out in the wash. There was no real change in the makeup of our legislature here in Montana for the next legislative session. So we'll continue to have the infighting and all of the chaos that goes along with it in the next session in Helena.
Any other comments about policy? I get a motion to accept the committee report. All second favor?
Aye.
Same side. It passes. Safety and quality, Flannel.
Okay, so I just wanted to start with the fact that my wife accuses me of having intermittent numerical dyslexia. first of all. And so I wanted to wish happy birthday to Brent. Well, he had a recent birthday, and I think he's 50 something. Anyway, so we did have a quality committee on June 2nd, and wouldn't you know it, the topic of the meeting was our public health during the same month that our accreditation application went in. So we had a very long and detailed review of all of the factors that go um, into accreditation, and we asked in the minutes that, and in fact in upcoming meetings, that we have a glossary of acronyms. So if you read the notes, you'll see that in the beginning, because there are a lot of acronyms and sometimes we forget what they all mean. Anyway, so we talked about basically workforce development, what foundational services are, and just to remind folks, that they include communicable disease, chronic disease and injury prevention, environmental, public health, maternal child family health, and access and linkage to clinical health. We talked about how, RiverStone provides services by contract to Carbon, Bighorn, and Wheatland counties. We talked about some of the other consortia, including One Health, which serves Gallatin, Bozeman, Park, Livingston counties. We're such a rural state that these counties have to combine in order to provide the required services. We talked about how the workforce is brought in, how they're oriented, and how they are trained, and how we make sure that they are all up to date. And basically, there was just a lot of detail on how the workforce is organized and trained, and how we make sure that we are able to meet all of the requirements of accreditation. So I think that probably just kind of overall says what we talked about, but there's a lot more detail in there, and I encourage you to take a look at the minutes. But I'm not sure that going into any more detail will really help very much. So there you are.
Any comments
Any
or questions?
questions?
Motion to accept.
So move. Second.
All in favor? Opposed, same sign.
All right.
Minutes are accepted. All right, governance, last month, the report was missing the policy that I just passed out. Apologies, my oversight. We have recently experienced more public input than I am used to in my tenure on the Board of Health for 14 years. So we decided we should document a process of how we receive the public in all of our meetings. So committee chairs, this also applies to committees. That is what we have done here. And ask the visitors to leave their name and phone number and email address so we can contact them. I'll give you a chance to read it and answer any questions.
I think the key thing is that it's a time for just receiving the information and like it says, time for debate or discussion.
Agreed.
And that it can be tempting also.
Yep.
To do that. So
That is key, and then it gives the chair, either of the board or the committee, the authority to control the time. Get their meeting handled. Get the meeting handled. Other comments or questions?
Maybe just one question on that second bullet point. So the normal time limitation for public comment, and that's in total is 3 minutes.
Yes, unless the chair gives them more time. And the idea, I think, is just introduce the topic. We don't need to get into detail. You know, we don't need a bean counter bringing in a whole bunch of reports and walking through the preparation of the reports. We need to understand the issue, and they can submit reports and any analysis they want through other processes, or even leave them with us at the time. But it is for comment, not for in-depth examination.
With council and those things outside of when they have public comment, they basically limit it to 3 minutes. So that's fairly common, if I'm not mistaken. Brent, you would probably know better than I.
yeah, that's been standard. Sometimes leeway given in individual case, but yeah, it's unless it gets out of hand.
And if it gets out of hand, then you can constrict it, right?
Yeah.
Then you whack them.
I don't think we're gonna have an issue.
No.
Here, so,
No, just so we can manage and get to our agenda. Busy days.
I guess technically that should be done at committee meetings too, then that should be on the agenda for each committee meeting, so.
I think the chairs should be aware they need to allow for public comment.
For clarity on bullet 2, would it help to say normal time limitations for public comment? Should that is 3 minutes per commenter?
With me,
Is it per commenter or is it a total of 3 minutes for the public, any public?
individual,
Oh,
I'm sorry. I
Because that was.
misunderstood. Okay. Yeah, per individual. Yep. Thank you both.
Let's see, we call for approval of this, is that right?
I will.
Yeah, so I'll move we approve that and just add that.
As amended.
That's my motion.
Just maybe one follow-up, is there some thought to just having, can we put a maximum limit of time dedicated to?
I think my thought was I would do that on an ad hoc basis. If I've got a busy agenda,
In the Montana Public Meeting Code, no.
Okay, I was just curious, like, we had some hot button issue, and had 40 people lined up,
Yeah.
each get 30-minute comments.
Sometimes we've done like the state legislature, will say on a big hearing, we're gonna have 2 hours.
Yeah, you could limit public
First member
conversation.
can talk and then after that, you just give your name. So again, we're not gonna have that issue.
Yeah, right. Yeah. And I remember,
I hope. Maybe now we will if we adopt this policy.
Well, we've had the policy. Now we're just we're updating the policy, the policy. So, you know, I think we've done some pretty lively things of late and we've even had lively conversation. Most public conversation we had was during the Clean Indoor Air Act, and I don't think we even had that many. I don't know. I wasn't here, but
No, it was
maybe 10 to 15 or less.
I don't think that many. Yeah, it was never an issue then either, like the time per person, so.
But the idea would be to encourage folks to share their input, to come to the meeting, but also have enough time so that we can input their ideas and then put the meeting forward.
I remember back when we took on vaping, we had that special meeting just for public input. I don't remember how we announced it or managed other meetings to keep vaping commentary out of our regular meetings, but
Maybe if we have one on vaccinations, we'll get more people. So,
yep.
And just like, why talking to things on the agenda is so important, because just like any other public meeting or forum, we can only address and talk about things that are on the agenda.
Other comments?
I think it's good that we clarify these things. When we had the open meeting on, I think it was distance, the smoking, outdoor smoking around buildings. And all the comments, one gentleman made some comments that were factually wrong. And I corrected him and got chastised greatly by the board for speaking and was told, you should have shut up.
do you remember that?
I know, I remember. So it's nice to get that reminder to keep my mouth shut.
Other
He's been
comments?
waiting 5 years to say that.
I get a second on the motion Brent made. Did you say yes, Coach?
Yeah.
Okay. All in favor of the motion?
Aye.
All right.
Opposed, sign. We approve the policy. There are two sets of notes from executive committee in your package. We met briefly 2 different times. We are addressing John's annual review. And continue to do so. One change in process that we are implementing is through the course of this year, John Dale Anderson, the CHC chair, and I have met quarterly to talk about progress against goals and anything that was rearing its head that we should, in the realm of RiverStone, all things RiverStone, we needed to address. It came to my sense was it would be best if we coordinated all of our thoughts. That is, John, CHC, and the Board of Health come up with a single set of objectives for the year for John to focus on. Because we would sit down in John's office with 3 different focuses. We had CHC and the Board of Health was consolidating, but not John. And I don't say that negatively, other than the process. It isn't as smooth as if we were singing from the same song sheet. So that is the effort we are going through now, trying to come up with a common set of objectives for John. And we boiled that down to 4 or 5 things in last year's 4 objectives. Last year, so we're going to try to do the same thing again. One of the challenges that we have right now is the CHC board chair has just stepped down, Dale Anderson, for health reasons. So on an interim basis, at least Tom, I can't think of Tom's last name this morning. Singer is assuming that role, so I'm trying to bring Tom up to speed where we are and the path we're headed. So if any of you have thoughts about goals or objectives not on executive committee, please fire them my way or through Carrie to me. That would be appreciated. And then secondarily, we're talking about KPIs. KPIs, I think, are conceptually a challenge to the organization, not being used to using at least the vernacular. And the staff has been working diligently to come up with them. CHC board is talking about them and trying to come up with them. Executive committee has tossed it around a bunch among ourselves and is trying to force that back onto staff, really, to come up with the KPIs, trying to turn it back around that way. It could be that executive committee would we aren't to the point, but we've discussed the use of getting a facilitator, someone to engage the board, the SLT, and the CHC board in a dialogue to try to understand KPIs and at least make a first pass at coming up with some. As an example of a KPI, a year ago, 18 months ago, we set goals for days cash on hand that Shanna speaks to every month. And that would be an example of what a KPI is. That's what it is. So we are trying to manage to that objective. And it's something that is numerical, it's something that we can explain why we move closer to it or why we move farther away from it on a monthly basis. So maybe for the groups to work together, do some brainstorming, try to work through the barriers. Executive committee is looking at the chance that we could use a facilitator to help us get to that point. So we've regurgitated all that. Any comments or questions?
Jim?
Yeah.
Have we gone through and evaluated how John did on meeting the 2024 goals?
That is in process. If you have any thoughts, please get them to the executive committee.
Might send us out the goals again, because I can't remember.
Will do. Other comments or questions? Hearing none, can I get a motion to accept the executive committee minutes?
I move we approve the May 27th and the June 8th meeting notes.
Second.
All in favor?
Aye.
Oh, same sign. Thanks. The minutes are accepted. Any new business? Mr. Forte, it looks like your name's here.
Yeah, look at that. Figured I'd give you all a better overview of rural health transformation. We've talked about it in certain committees and we've talked about it as an acronym we all need to be familiar with, but haven't really given it a deep dive into what the heck it actually is and what it could mean. So I'm going to do that today. Just make sure I can share the deck here. Maybe not. There we go. All right, so when we say RHTP, we mean Rural Health Transformation Program. And so across the country, we've got $50 billion, sounds like a lot of money, allocated by Congress, thanks to HR1 or OBUBA. That's one big bill act. The funding is intended to offset the negative financial impacts of the bill on rural health. And so by federal definition, Montana meets all areas of Montana meet the definition of rural health. Montana has then chosen 51 out of 56 counties as rural and 47 out of 56 counties as frontier. To provide some, additional resource breakdown for other areas across the state. But if the math ain't mathing for you, It isn't for me either. And you can see plainly that $50 billion isn't really an investment. 50 billion over 5 years does not equal the anticipated loss of $155 billion over the next 10 years due to the cuts to Medicaid, to the social safety net, to other programming that is outlined in the rest of HR 1. So this is just one piece. So out of that 50 billion, Montana was awarded the 4th highest monetary award in the country, behind Texas, Alaska, and California. That's $233.5 million. So that money can change. We can get more or we can get less. We think due to our stature as a state and our rurality, we will probably get additional funds over the next 5 years. But any new funding is based on performance in year 1. So the performance of this year moving forward will dictate, if we get additional funds here in the state of Montana. We could also get additional funds because other states may lose theirs. And so CMS has already begun denying plans in states like Massachusetts, California, other, bluer states across the country, and said, no, you can't do that. And if you continue down that road, we'll just pull your money back and give it to somebody else who is doing something we want you to do. So there are a couple different ways where we can get additional funds out of this process. Here in Montana, the Department of Public Health and Human Resources is managing the allocation of funds and has created the vision that they want to support rural health providers in delivering sustainable, high-quality care and ensuring appropriate access for those in need of services. And so the 5 ways that they're going to do that, these 5 initiatives, is through workforce, rural facility sustainability, care innovation, community health and preventative infrastructure, and technology. And so break down each one of those and where the 233 breaks down individually. So initiative 1 is really to develop Montana's rural health workforce, recruitment, training, and retention. And they've put $21 million in that pot to focus on making Montana a place where people want to come. And so one of the things we were trying to do regionally was a talent attraction campaign. And for the healthcare hub of Billings, say to folks throughout the state and the Mountain West, hey, Billings is a great place to come be a healthcare provider. So that's some of the money that is going to go to that. Important to note the word existing here. The goal is to expand existing residency programs. And we did a lot of work massaging this investment with the state because starting new residency programs takes a lot of upfront cost to build out infrastructure, to build out program development and direction, hire the staff, etc. But invest in the existing residency programs that we have, like MFMR here, internal medicine and psych up the street, and the Western Montana Family Medicine Residency in Missoula. Offering preceptor incentives and training, DLI, Department of Labor and Industries, working on that. And as I go through each one of these initiatives, I've bolded the activities that apply directly to us as an entity. And you'll also see something missing throughout this slide deck, and it is the 2 words public health. And so we're working with the state and other entities across the Montana to help them understand why investing in public health workforce and public health programs is going to be vitally important to the program success. So we've got preceptor incentives, professional training and support. So to help our APPs, to help build dental hygienists, midwives, EMTs, medical assistants, putting a lot of money into the apprenticeship program to develop more healthcare apprenticeship programs statewide. And then rural healthcare training, programming, education, and conferences. Initiative 2.
Sorry.
Okay. Rural facility sustainability. So $82 million is going into a Center of Excellence program, which is slated to be awarded. I can't say publicly yet to who, but it is someone that we work very closely with and have a great relationship with in the state as an organization representing healthcare entities. And so we will have a good relationship with the Center of Excellence service provider and hopefully be a beneficiary, trying to link and create connections with telehealth, rural hospitals, statewide specialty care, mobile healthcare development, crisis care and behavioral health spaces, as well as population health investments. So a lot of good work to come here. Out of this program, we are choosing to opt in to participate in the Center of Excellence program. And there will be a flat fee that participants will be able to obtain as a couple $100,000 to start work on making sure that we're able to create better partnerships and create better service structures. Eric, do you know off the top of your head what that number is?
The exact amount of money.
Yeah.
No, it was in the 200,000 to 300,000 range.
Yeah.
There were a couple different there's a couple different kind of like I call them participation trophy money. One is to just to participate, and then there's a second one that is related to IT infrastructure development for recording purposes. So
yep.
And I think they're both in that $200,000 to $300,000 range.
Yeah. So we'll make every effort to do things with the Center of Excellence program. Initiative number 3 is innovations in care delivery and payment models. So there's opportunities to expand and strengthen value-based payment models in the state, as well as strengthen EMS and pharmacy services. And so one of the things that was announced several weeks ago now, Intermountain is starting a new EMS program out in Warden Huntley in the eastern reaches of our county. And so we're in conversations with Intermountain on what would a community paramedicine program look like? What would a paramedical EMS diversion program look like to keep EMS providers in their service area? And so instead of going and coming down to the hospital, taking 20 minutes to get downtown, taking 30 to turn around and go back home, what if they could drop a patient off at a RiverStoneHealth clinic in Warden who didn't need an emergency room visit, but just needed to see a provider? Those are some of the alternative, less costly programs that we're trying to look at to work with our EMS providers around the region. And then also hospital at home programming, and what does it look like for preventing high cost interventions and keeping folks in the home. So we'll continue to monitor that.
What are the payment models with that?
So there's a couple different models that exist currently. One that we participate in is called Montana Health Plus, and it's almost it's a managed care Medicare program where it's value-based payment. We get paid for how well we take care of our patients. Are we preventing hospitalizations and chronic illnesses from flaring up? And so that's really value-based care at a 1,000-foot level. They're looking at how do we expand value-based care. And so the primary care PCMH program that the state ran and paid us for as an FQHC to take care of our payments is gone. They've eliminated PCMH, and they are moving into a primary care Montana model that is a 3-tiered value-based model. Every FQHC in the state is participating at tier 2 or above, and we're the only ones that have left tier 1. So there's less money available in tier 1 for normal primary care providers. There's more money available in tier 2 and tier 3, meaning if we're taking better care of our patients, if we're coordinating their care better, it's all of the things that bread and butter of a federally qualified health center that we do. We've moved into those higher level tiers so that we're wrapping our arms better around our patient, trying to manage outcomes in a more manageable way. And we're going to get additional revenue or reimbursement to do that care coordination work. Keep folks out of the hospital, keep them healthier. That's the whole goal. We as an entity have still decided that we will always work to maintain PCMH certification and programming, even though the state is moving away from it. You used to need to be certified to participate. Now all you have to do is check a box saying that you act like a PCMH facility. We're not going to just check the box. We're going to do it the right way. Initiative 4, community health and prevention. Funds for infrastructure upgrades, incentivize healthy lifestyles, increase healthcare access points. So this would be an innovative program that we've been developing for years, like the Live Well Center, where we're implementing physical fitness, diabetes education, diet and nutrition counseling, and working with folks to improve their health outcomes, lower obesity, improve diabetes outcomes, those sorts of things, as well as school-based health centers, mobile crisis, as well as the crisis facilities and behavioral health coalitions. We're going to play a lot in Initiative 4. FQHCs are specifically mentioned in Initiative 4 of our state's application. And so the Primary Care Association is going to take up a lot of this coordination and work to help us here. And so we'll continue to improve community health and preventative infrastructure. That's what we do. And this is where we were trying, like hell, to get them to say the words public health. But they're saying it without saying it. And this is where we'll have to work on applying as a public health entity to achieve some of this money. And then 5, in technology and innovation. This is Big Sky Care Connect is going to be one of the big winners here. And they're going to use their technology within the Health Information Exchange to help connect the dots and connect the missing pieces that exist throughout the state so that we can have better data flow and information, that we can fix some of our behavioral health system information gaps where the state didn't have an EHR at the state hospitals, so we couldn't get any information on the patients who were coming to us after discharge from there. It's going to create better ways for electronic health records to talk to each other. Whether you go to RiverStone, Billings Clinic, or Intermountain Health, we'll be able to have a full patient journey and see better data, work on improving outcomes, and see somebody's health condition throughout their life and their visit history, so that we're able to take better care of our population. Any questions?
Overall, or just on 5?
Overall.
Okay. So we got a nice share of the first year. Now, at the end of that year, is there some sort of governing body that will then look at the next, 10 billion and, reallocate then? I mean.
So it's all gonna be, it's very much a pay for performance model. So it's a performance plan. There's KPIs that the state has to deliver on. And CMS will then determine, all right, Montana, you met 9 out of 10. Here's an extra $200 million or whatever that looks like. Or, you know what, you didn't deliver on initiative 2 very much, so we'll cut that funding and we might give you funding for other initiatives.
Questions or comments, Michael?
Two questions, please. First, Megan, maybe, regards to the dental clinic. Are we fully staffed with providers to take care of all the patients that come in, especially dentists?
In our dental clinic
Yes.
here,
Yes.
yes, I don't have any openings. Yeah,
We are finally fully staffed.
the one PRN person leave, right? That is gonna staff, but he was mainly gonna do the mobile.
Yeah, we're still recruiting for a part-time as needed employee, but our regular
Regular
positions are
dentists.
filled.
The reason I bring it up, my dentist, former student, commented to me when he first came out, finished dental school and came back to town. He volunteered one day a week in the dental clinic here at RiverStone and commented how important that was to his career. All that he saw there that he didn't see in normal. And if we were ever short of dental providers, encouraging some of those new dental students to come in and volunteer and learn a few of the more complicated things that they didn't see in their training. Just a comment, nothing more, not even a suggestion. Well, maybe a little. Number 2, Shanna, there's a comment in here that I didn't quite understand. And this is back fiscal year 27 final proposed operating budget. And there's a comment there about, maybe I should read it. Overhead is decreased from fiscal year 26-27 through reallocation, resulting in a projected overhead rate of 17,000 per FTE. Can you explain that to me,
Yep.
please?
So that's kind of a number that we track internally, is just how much overhead we're allocating per FTE. So for context, our fiscal year 26 budget was at 19,200 per FTE. So our total administrative costs divided across our total FTEs of the organization. This year, our proposed budget is about 17,200 per FTE. So just showing that decreasing trend in the administration costs. I mean, essentially a couple of fiscal years ago.
So it's 17,000 per FTE,
For the whole year.
but that's just the administrative staff.
Yep. So essentially the administrative costs, so not just the staff, but anything associated with the IT, the fiscal, the admin staff, the space across the building, all of those admin type costs spread across the organization. So each month we take and do an overhead allocation to each program within the organization. So we look at the FTEs within those programs and we code out the admin costs and overhead allocation based on FTEs that are within those programs. And so we just monitor that because a few years ago that they got really high. So something we're just keeping in line to make sure that our admin expenses aren't too high across the organization.
Where do you put the depreciation? That in admin?
No, it goes, it's just on across the organization, depending upon kind of what area, for specifically like clinic has a lot of it based on the building.
Okay.
Administrative costs always interest me.
Yeah.
Sorry, another comment real quick. When I was in New Mexico, and I was surviving on grants, federal grants and contracts and such. And the university's overhead cost was 77%. The final year I was there, 77% on top of the grant request.
Yeah.
And was going up to 83% when I finally left.
Yeah.
So I've always been
No,
wondering about administrative, and it seems like our administrative costs here are very low.
they are low. I mean, max 15. A lot of our grants will only allow 8 to 10%. And so, yeah, that would be way too high. We were looking at 77.
some universities at the time were over 100%.
Yeah.
It was outrageous. But sorry for the comment.
No, I
It
appreciate it.
helps me understand a little bit.
Yeah.
Thank you.
Other comments about John's presentation? Questions? Any questions or comments about the meeting overall? Got plenty of time for a quick roundtable. Lionel and Steve, are you still there? And if you are, Lionel, why don't you kick us off? Any thoughts about today's meeting?
I was glad to be able to join you all. You all look, you're very telegenetic, I think. You all look good. But aside from that, no, I thought that the John's last presentation about, this money that's coming to Montana was very enlightening. I think about other states like, say, Oklahoma or Kansas, or do you know where they rank as far as money, and or which states get like the least amount of money? How are they going to fare? Do you have a
That's an interesting quick Google. There's an RHTP tracker out there that kind of lists by state what you're getting. Ours was 233.5, fourth out of 50. Oklahoma's right behind us, the fifth out of 50. So yeah, there's a bunch of different stuff out there. A state like Pennsylvania, 34th out of 50. Florida's 14th out of 50. So they've got a lot of
New Jersey, I would expect they're not very rural at all.
Jersey's
or
50th.
Delaware.
Yeah.
Yeah.
Helps
Okay.
in red state, right?
It does help to be a red state. Delaware. Once you get out of Wilmington, it's a lot of poultry. I bet lived there. 47 out of 50. So
Yeah.
it's super interesting to see how the money was spread across.
I mean, interestingly, California, not a particularly red state, but actually it's so big that it's actually in many areas quite rural.
Yeah, I do think they did a decent job of spreading the money based on rural population first. That was their primary measure. And then they took a look at each state's individual application and said, what is the state actually proposing to do? How does that meet the mark within what CMS wants to accomplish? And then kind of gave supplemental funds based on some of the more tangible outcome deliverables.
Yeah. So, well, thank you. No, I thought the meeting overall was very informative for me, and great minutes, Carrie.
Steve, any comments? We have lost it. Aaron? Any comments, Coach?
I was glad to see we plan on resuscitating the foundation.
Amen. Brent?
John.
Okay.
It's out of the ICU. It's back on med surg. Okay.
We're covered. Michael?
Still intubated.
Thank you.
Benjamin?
No, thank you.
All right, we are adjourned.
Thank y'all. One